I'll
Sir,
first give the
5,
presentation.
4,
Okay.
Yes.
3,
And then invite you for the comment.
2,
This is
1.
the,
Sir, start.
we are offline, right?
Yes,
We
sir.
are offline, right?
No, sir,
Offline है
we're
ना?
online.
सर वो स्टार्ट करेंगे ना
हाँ, we are not online anymore, right? Online है ना? Online हो गए.
Yes, sir. Please start, sir.
Morning we are operating.
So, good morning, everyone. Myself, Dr. Nishikant, medical advisor at Alkem. A warm welcome to the today's live dental workshop, Dentex, dental education for the next generation treatment expert. So, today's program is organized by the Alkem Laboratories in collaboration with Department of Conservative Dentistry and Endodontics, Government Dental College and Hospital, Mumbai. So, Dentex is our Alkem educational platform dedicated to enhance the clinical excellence in dentistry through expert led training and live surgical demonstration. So today's workshop brings us two surgical demonstration of two advanced clinical cases in dentistry, apical root end surgery for the molar tooth, and second surgery will be the microsurgical management of mandibular cystic lesion. So we are privileged to have us with three surgical expert of Indian dentistry, Dr. Sanjay Joshi, Professor and Head, Terana Dental College, Navi Mumbai. Dr. Abrar Syed, Professor and HOD, Department of Conservative Dentistry and Endodontics, Government Dental College, Mumbai. Dr. PG Joshi, Consultant Endodontics, Leelavati Hospital, Mumbai. A warm welcome to today's expert. So let's begin our today's live surgical demonstration journey. So today's program, the first surgical intervention will be the molar apical root end surgery by Dr. Abrar Syed, and second surgery will be microsurgical management of mandibular cystic lesion. So now I hand over session to Dr. Zainab for the case presentation and introduction of the today's surgery. Over to you, sir.
A very good morning to one and all. It is a pleasure to connect back to everyone in this session 4 of the series of microscopic cases that we operate and telecast it to you live from the operating room. So open, unedited, and complete videos, and that are absolutely live. We are blessed with the entire team of Government Dental College and Hospital and various departments supporting us. At the outset, we are thankful to the Department of Oral Medicine and Radiology for all the support of diagnosis, imaging, and guidance they have provided us with. We are blessed with the support of Department of Oral Surgery, Dr. Abhilasha, extending their manpower to us and their expertise, and they will be participating with us in the process of surgery today. At the outset, I want to thank to Dean Madam for granting us permission to continue with this program again. To come back to the original plan, today in the morning, we will be operating a case of periapical extrusion of foreign body, most probably calcium hydroxide, the entire bolus lying in the premolar region of a female patient, which is not resorbing and causing continuous pain and other symptoms to the patient. So in the last few surgeries, those who have connected to us previously, or they can go to our YouTube channel and see the surgeries. This is like a mushrooming cloud of a periapical calcium hydroxide material. This was operated live on the YouTube previously. This was the post-operative, and we are still tracking the patient, is doing well. This is another case of resorption in a foreign body that we treated. Today's case is a female patient, 59 years old. She reported to us with swelling in the jaw, in the mandibular left area, premolar region. Extraoral pictures, No extraoral deformity or swelling was observed. Intraorally, things appear reasonably optimum. This is the occlusal image, missing teeth in the upper arch and a few restorations here and there. And this is the lower arch in question. This is the mirror image. So this is the left side. 4 is the tooth in question. Patient has symptoms with. 5 has been endodontically treated. 3 also has been endodontically treated. This is the occlusion. Nothing out of the ordinary for the occlusion except the missing antagonizing tooth. Preoperative, intraoral, periapical radiograph indicates a reasonable obturation, clinically acceptable. Slightly the burr was laid astray here, but however taken care of, doesn't seem to have a perforation or a related lesion there. However, with the second premolar, if you see, there has been good amount of extrusion of the material with a condensed body of the material with some stray spread here and there. So on further investigation, the OPG indicated the extensions overall, a cystic lesion being seen without a very clearly outlined border, however, on the OPG and slight extrusion of the material related to the canine as well. Sagittal image shows a very clearly outlined radiolucency in CBCT along with the foreign body material, which again probably appears to be calcium hydroxide. Axial section also verifies the same, but the material is almost touching the lingual cortical plate. The osteolytic changes, those have happened in the cystic lesion, appear to have caused resorption of the trabecular bone inside the body of the mandible, caused massive destruction of the buccal cortex, as well as causing the perforation in the lingual cortex. So, surgical plan will be not to push it in the somewhere in the lingual space, but to confine ourselves here and to dissect the lesion from the periosteal lining of the lingual cortex. So we have a very gentle job here to perform, that we go in surgically, we curate this out and safeguard the the lining of the periosteum and curate out the lesion accordingly. So that's the case, and that's how a microscope is being used for. These are paraxial images of different sections where we can see the same. Good amount of buccal exposure will be found as soon as we raise the flap, and we can go in to dissect the lesion. Size appears to be quite bigger here. 3-dimension. Lucky for us, the foramen appears to be quite distant from the location of this, but however, when we handle the tissue, there can be some amount of pressure pulling coming onto the nerve, giving rise to some temporary paresthesia, which the patient has been explained about. Report from the CBCT, Department of Radiology. They have given differential diagnosis that infected radicular cyst. Conservative management could have been thought of if the defect would not have been so extensive, bicortical, and causing continuous symptoms. Because we know that after a certain period of time, if the calcium hydroxide remains inside, it does not undergo resorption, acts as a foreign body, needing further management. So this was the case. Kindly post all your questions online on the YouTube. We have a subject expert. It's a pleasure and honor to have Dr. Sanjay Joshi, sir, Professor and Head, Department of Oral Maxillofacial Surgery from Terna Dental College. Sir, please, over to you. So kindly start posting your questions. It has been a history with us. Thank you so much for being with us, sir.
Thank you very much, Dr. Abrar, for having me here.
So graceful and so selfless of you to accept
Indeed,
our
a great
invitation.
privilege to be back in my alma mater. And the cases that Dr. Abrar's department has been doing over the last 4 sessions are indeed extremely complex. And all those who have viewed it, I am sure, are fortunate to have witnessed technology being used for better results as far as endodontic root resections and root surgeries are concerned. So we look forward to a more session which is more interactive than just one way. Thank you.
Thank you so much, sir. And kindly start posting your questions personally on the chat in the groups or on the YouTube. It's a pleasure and honor to welcome and receive Dr. Lata Khobragade, madam. She is a professor and head of the Department of Dentistry in JJ, GMC of Grand Medical College. Thank you so much for coming, ma'am. So we request you to say something. Express yourself. Okay. Thank you so much. Once again, a big thanks goes to Abhilasha, ma'am. Please come. Manoj sir, Kishore sir. Just a short formality of a group photograph here with the faculty members. We have here Dr. Manoj Ramogade sir, Dr. Kishore Sapkale sir is with us, Dr. Sangeeta madam, Dr. Jyoti Wankhede, conservative, Dr. Fatima, who's been coordinating with everyone, Dr. Bala, come. Alisha, idhar aa jao. Dr. Kiran, one minute. And the main pillar, Dr. Joshi sir, please, center. Sir, sir, आप इधर आइए, सर इधर आइए. Please, आप इधर. Okay. It takes a lot of effort to put this entire show together. So we thank each and every member of the team for being there with us. Unfortunately, nobody from oral radiology diagnosis could be here with us because they are in some meeting. We thank them. So over to the surgery directly now. Thank you so much, everyone. Thank you. Thank you. On hai, mic? On hai. Okay.
So for the benefit of all those who have joined this session, I will just take you through the case once again. So we are looking at tooth number 3-4, which has a large periapical lesion. As you can see in the OPG, there is extrusion of calcium hydroxide. This was prior to the obturation when dressings were given. So lesion seems to be quite large. In fact, the lesion reaching the roots of the canine, also reaching the roots of the second premolar and falling just short of the mental foramen. So after the obturation now has been done, and as you can see and explained by Dr. Abrar earlier, there is a perforation of the buccal cortical plate already. There could be a small perforation or dehiscence of the lingual cortical plate. And the extent of the lesion mesiodistally is quite large as compared to what you see in the OPG. So these are the sections that you can see the lesion and thinning of the lingual cortical plate at many places, but I expect that there may not be a clear dehiscence, and that is the beauty of the nature. So aim is to get this extruded material out, all the granulation tissue to be curated and followed by apical root resection and retrograde filling under microscope with, and are we going to use MTA? Are we going to use MTA for this? We will use MTA for this under the microscope. So we'll use ultrasonics to create remove the GP from the apex after apical resection and seal it with MTA. That's the plan. And if I see so these are the after obturation radiographs after the final obturation has been done. And the flap that is going to be raised for this procedure, patient has been given inferior alveolar nerve block on the left side. Also infiltration has been given locally in the area of the surgical procedure. And the flap that is going to be raised is, we give a clavicular incision first, say from the lateral to the first molar, and releasing incisions in the canine region and in the area between the second and the premolar and the first molar to raise a envelope flap completely. Okay, so now we will go on. The procedure is starting. So I take you over to the operating chair. Thank you.
मेरा माइक ऑन मत करो 1 मिनट के लिए। किशोर सर को इधर बुलाओ, किशोर सर को इधर बुलाओ, किशोर सर को इधर बुलाओ 1 मिनट के लिए। हाँ, मेरा माइक ऑन है। मेरा ऑडियो चालू किया है, मेरा ऑडियो चालू किया है। तो सर आप चेयर पे आराम से बैठ जाइए। हाँ सर, आप भी बैठ जाइए। मुझे लगता है कहाँ आप खड़े रहेंगे? नहीं, आपको बहुत काम करना है, आप बैठ जाओ आराम कर। अरे नहीं सर, खाई के लिए बैठ जाओ ना आराम से, छोटा है। हाँ, किधर भी आप बैठ जाओ। सिट सर। चलो, विल स्टार्ट। कैमरा इज ऑन, ऑडियो इज गुड। So the plan here is that we have choice of anesthesia. We have given her lignocaine 2% with adrenaline, inferior alveolar nerve block, followed by buccal infiltration. So buccal nerve as well as inferior alveolar has been taken care of. And the local infiltration that we have given ensures that local hemostasis happens, tissue separation is good. So that gives us better retraction, blunt dissection. At the same time, we get a good hemostasis when we work, because when you work in the periapical area for root resection, it's a very small area that you're looking at with a microscope. Even a smallest bleeder could obscure the entire field and keep us from doing appropriate retrograde preparation with micronodic tips and doing that compaction or washes away the bioceramic material that we want to put in the cavity apically. So taking a break just for a minute's time, I welcome Dean Madam here. I'm so sorry. We're about to start. Get Madam here. Ma'am, please. Get a microphone to Madam. Madam. Ma'am, please.
First session.
Come here, come.
Is it something we are organizing this?
This is the 4th session, ma'am. 8th case we are operating today. Session 4, case 8 we are starting.
Okay.
As we started at the outset by thanking Madam for all her motivation and support and permissions granted here, we welcome Ma'am to the program. Ma'am.
Yes, thank you. This is the 4th session. I really appreciate the efforts of the whole team headed by Dr. Abrar and Joshi sir. All are always keen to teach. This teaching is an art, and they are motivated to teach as many youngsters as possible, and we are getting a very good response. So there are youngsters who want to really learn. So good work done by the department. Hearty congratulations to the whole team. Thank you.
We are lucky that in last 3 sessions, more than 10,000 people have registered for 3 sessions and participated. So we are very thankful to you, ma'am, for all the infrastructure, all the permissions which are granted to us. And we are thankful to our delegates and viewers and the people who register. And thank you so much. We request you to continue your support. We learn from each other. We get excellent feedbacks from the participants. We have been really helped, guided, and motivated looking at the type of comments that we get and the kind of queries people ask. The objections which are raised are really academically oriented, and they act as a guiding torch to us for further excelling in the field, whichever we are working in. Thank you so much to all of you.
Hello,
And once again, thanks to Dr. Lata Khobragade, ma'am, head of the department, JJ.
Acha.
JJ आपले GMC dental department चे HOD
Acha.
professor.
Oh, yes, good. Good.
Abhilasha madam has also supported
Oh.
thoroughly, ma'am.
Acha. Hello.
Thank you.
Thank you.
We have given the infiltration around 5 minutes back, so we are good to go with incision making in this. Meanwhile, a lot of participants have posted a few questions to us. I request our subject expert, Dr. Sanjay Joshi sir and PD Joshi sir, to collectively answer the questions. I am starting with a flap design. I will discuss in a minute's time, then over to sir for the responses.
Yeah.
Now, in
So-
this case,
Go ahead.
we have this canine, first premolar and the second premolar in question. The lesion is related to this tooth. So I'm going to make an incision mesial to the canine, not including the papilla, and distal to the 5, not including the papilla, going distally.
थोडं शार्प पाहिजे.
Bar फोकलिंग नाही आहे सर मला
बस ठीक आहे.
Okay.
फर्स्ट क्लास.
So clavicular incision, we'll make it first.
परत सांग बा. 1-4
1, 2,
5-7.
5, 7.
Lock it. Lock it there, beta. Lock it there.
So one of the questions that has come right in the beginning is how should we diagnose the case properly? So you want to. So when it comes to diagnosis, it will have to be a combination of clinical examination, history recording properly, past dental history extremely important, followed by, of course, investigation in terms of radiography. We can do routine radiovisiography. And of course, now we have the access to cone beam CT scans, which help us further to understand the dimensions and the depth of the lesions that are always there.
बराबर है ना? Yeah, this is the
So, that is how you will diagnose. Of course, patient history, as I said, is very important. And based on these factors, you can come to a diagnosis whether the patient is having a periapical pathology and whether it will need to be treated surgically. The question is whether you need surgical intervention in all the periapical pathologies.
You take it from this.
Depending on the size, the extent, the evidence given by the patient in terms of signs and symptoms, all this will decide whether surgical intervention would be required for a periapical pathology that exists around the dentition. Right. Another question that has come is, so this is what we are doing today. So today what we are doing is not a tumor, neither it is likely to be a properly a cyst. It is a periapical pathology, and you can call it more of a to be a granuloma. Post-operative medications after the apical surgery will include a routine prescription of antibacterial therapy and anti-analgesic and anti-inflammatory drugs, along with a mouthwash, just to make sure that the wound remains nice and clean. In regards to the ultrasonic tip, it will be demonstrated when it will get used, so you will know what tip is getting used. In chronic periapical abscess, is single visit RCT preferred, though it is outside the purview of this. I don't think in chronic lesions you should go ahead and do a single visit root canal therapy. So once again, I would request all the audience to restrict their questions to the case that is being done today, because we are not in a position to answer everything about endodontic, because there are a lot of questions related to
Let them
endodontics.
take care. No problem. Endo will answer, sir. Sir,
Okay.
you pass on endo question to him.
Dr. Abrar is kind and
It's okay, sir. It's a very informal discussion.
Acha, okay. So another question that comes is, which water-based calcium hydroxide is good for intracanal as an intracanal dressing or medicament?
Okay, that's a question which is very relevant from this case point of view. Because if somebody has used calcium hydroxide with Metapex, with the iodoform in it, Metapex or similar kind of material, then it can actually cause necrosis of the periapical tissue and can cause more pain, more swelling, and further complications. So you do not want iodoform to go into the periapical tissue. So ideally speaking, one should use aqueous calcium hydroxide, which can resorb very easily in the tissue.
Okay. And what else is the question we have?
Periosteal elevator. I have taken a clavicular incision is complete and one releasing incision is complete here. As you all can see, now we'll start with the dissection. Raising the flap.
Another question that is there is, which is the best apex sealer?
Best
Apex sealer.
apex sealer.
Yeah.
Now, in such kind of cases, if we just talk of this surgery, then MTA or bioceramic material would be the best apical seal.
So for retrograde procedures, when we are doing an apical surgery, traditionally earlier, all of us know that we have been using amalgam in the past. we have used glass ionomers in the past. We have tried to use composites also, if I'm not mistaken. But the current literature supports use of MTA, and it supports use of now also use of bioceramics. And of course, there is a learning curve for both of these materials as far as handling is concerned, carrying this material to the desired location is concerned. If all that, but that these are the materials, bioceramics and MTA. MTA now has been, I think, in use for more than a decade now.
2 decades, sir.
2 decades that MTA is in use, and it has proven itself to be a material giving good results. And now, of course, with the advent of bioceramics, we will know their results also, which are already promising, I believe. So these are the two materials which are currently the best suited for retrograde apex sealing post endodontic root resection, or either a traditional or you do it microscopically.
Beta, yes, sir. Which shall be
We'll wait for other
it
questions.
in the same vicinity where instrumentation is happening. It's mandatory. As you can see, we have levated the flap through the releasing incision that side. So I had kept it reserved because of the contour of the bone. We have changed the plan and extended the incision to the area of the molar tooth. हाँ करो थोड़ा सा retractor here. Yes, a good amount of retraction is mandatory. Yes. You can see the bone. Yes, the retraction. Now, as we have separated the papillas and you see an attachment here, we remove it, dissect the bone more. This is 5, this is 4. This is the canine, and this is the pus coming out. You can see a clear fluid coming out. That is inflammatory exudate, a typical color in between a colorless fluid to a straw color. You can see the cavity directly, as very well documented on the images, radiological images, and gauze soaked in betadine. We can see the opening of buccal cortical perforation, raising the flap. Yes, this sound has to be there continuously, okay? So that if you can, BD sir would agree here as endodontics. Sir, this is definitely appearing to be a material with iodoform. You can see that my microscope. Yes, I am focusing on the deepest part where there is open. See this yellow thing I'm focusing my microscope on right now. Yes. Can you see that tissue, that material? That is the foreign body we are looking at. But right now we are not teasing it because we are first gaining access to the whole lesion. As we have discussed preoperatively, retraction please. Yes, good, beta, good, good, nice. As we have discussed preoperatively, that we need to salvage the lingual aspect. Well, so now I'm nearing the premolar area. I needed a gauze, soaked gauze, yeah. Section it out. Blunt dissection, crucial. We teach all our students to do blunt dissection more than the sharp, because having endodontic background, we are not that great surgeons, but definitely sufficiently trained to operate few basic cases under the guidance and help of the oral surgeon people. I can see the apex is compromised a lot and the whole foreign body has been exposed now. But still, I would like to do some dissection here so that my access is enhanced. 3 also, the bone is compromised. This is the root apex of the 3. I think I need to release the incision a little bit here. I'm extending the releasing incision. I will reduce the magnification for you all to have a more clearer view of what is going on. छोड़ो बेटा, अब छोड़ो retractor, हाँ. It is not giving me a very good approach to the apex because the releasing incision, I kept it a little bit more apical to the mucogingival line. But Sanjay sir, can I go more?
Yes, you can extend it even now.
I can extend it more? Yes. So that's how I get more apical exposure. I am not taking an incision at the expense of any muscle attachment there. I'm very superficial. Microscopic is showing me the fibers. You see, we have not destroyed. Our incision is strictly limited to the mucosa and the submucosal area, exposing the canine as well as the apex of the tooth tooth of interest. Okay. So now going back to, so now if you see, I'll get basically good exposure ensures good actions inside. If the exposure is limited, you keep on performing something and you don't reach the aim.
So
But I
all
have-
minor surgical procedures are a question of access. That is what is the biggest challenge. Access is the biggest challenge. Access and visibility.
ये retract करो.
And that is why we must ensure that we have
ऐसे retractor में होना
adequate
चाहिए.
access to the area of the surgical
Retractor here.
site.
Take the suction inside.
One of the questions that has come is any grafting procedure will be done in this case. As of now, there is no plan to put any graft in the osteolytic lesion, which will be curated and cleaned of any debris and necrotic tissue and foreign material that is there. But depending on person from the operator to operator, you may think of doing maybe a PRP or a PRF
No, no.
in these
Straight
sites. The size of this lesion is about centimeter by 1.5 centimeter. So mesiodistally, it will be about a
Equivalent.
centimeter. And buccolingually,
Retraction
it will
completely.
be about 1.5.
Coolant.
The complications that could be associated with this kind of a surgical procedure could be, of course, bleeding, number one. Number two, there could be tissue trauma if you don't reflect this tissue properly.
चालू करो, micro करो.
So
Coolant.
these are some of the common complications. Failure of anesthesia sometimes, of course,
Painful.
and patient will then have pain. So we are now doing Dr. Abrar is doing the resection of the root at the predetermined position with a micromotor and a Fisher burr, tapered Fisher burr. It could be 701 or 702.
The question that may come to everybody's mind is why the root resection is preceding the curettage and removal of the foreign body. As I told you, if there is an elephant locked in a room, might as well take down a wall and take him out, not try to take him out through a window. So what we are doing here is we have resected apical 2 mm of the root so that the foreign body comes out without getting dislodged into the deeper tissue spaces. As we have seen in the radiograph, that there is a perforation of the lingual cortex. We don't want to risk creating a mess, and we want to remove the material in toto as far as possible. So removal of those 2 mm made a window very large so that we can take out the lesion, the foreign body through current access. No, smaller.
And unlike earlier, the theory now is to give at the most a bevel of just about 0 to 10 degree and nothing more than that.
You can see the bulk of the material is out in one go.
Yes, now you can
We
see
did
the
not
foreign
want to
material
break
that had extruded.
from the apex of the premolar. This is the first increment that has come out. The main bolus that was very homogeneous. Now going after the rounded stuff, you can see that the suction has removed most of it, and this is a small extrusion. Oh my God, it's I can
Like a
actually
small
tug back. Yeah, it's giving me tug back. I have to bring
duck bag hai.
tugging me back.
Correct.
So it was surely not resolving. That is why it is so symptomatic.
So another question that has come is, can we use cautery for the incision? No, I would not recommend that you use cautery for intraoral mucosal incisions. It is always better to use, especially in minor surgical procedure. If we are doing major procedures like we do for an ameloblastoma or an OKC, which are larger lesions, then of course there is some tissue which we are going to sacrifice. In those cases, yes, I will tend to use a cautery. But when it comes to minor procedures like this, which I don't want any tissue to be charred or to be, uh, I will not use a cautery in these procedures.
This is the lining part, lining or granulation, whatever you call it as. We'll place it in a fixer solution and send it to oral
This
pathology.
will go for histopathology. Extremely important to have good instruments like sharp curettes of various sizes to do a good curettage of such lesions.
I will further use surgical scoops which come in various sizes to remove the remaining lesion. See, this is the lining I'm looking at. If you can appreciate, I will take it on a higher magnification later. Yeah, this is the lining of this lesion that we are looking at. I will dissect it through a smaller, rather than fancy instruments. Many times in microscopic surgeries or operative instrument help me a lot. I've been extensively using spoon excavator for surgical reasons in microscopic surgeries.
Correct. So those are the Lucas curettes.
Enamel hatchet also I have used in many situations, believe me, trim the bone at times.
A good surgical section extremely important for all these procedures because you are wanting to have a bloodless field as much as possible. Once again, for the benefit of all the viewers and those who have logged in today, the type of flap that was raised is one of the questions that has come back, is a trapezoidal flap. So we have taken a clavicular marginal gingiva incision and two vertical releasing incisions, one between the second molar and the first molar, and anteriorly between the canine and the first premolar.
I've gone in now. This is the lining. Quite stubborn, oozes out a lot. See now, this is a separation. I have received separation from the distal wall. Now adherence remains with the periosteum. Okay. We have not been able to dissect it from the superior wall. This is superior dissection. Mesial dissection is complete. I am dissecting it from the root surface now. See, this is the dissection from the root surface. You see that the stroke I'm using lingually around the apex. Now, another side of the curette being used to dissect it from the distal. Retraction, suction. बेटा suction इधर रखो. हाँ. It's a yes. Now gently, little bit इसको side में. हाँ, very nice, nice. This is the lining I'm looking at, and now I want to dissect that lining very peacefully and gently from this side. See, this is what I'm curating it. Here I use a little bit of force to scrape it out. See, the lining is coming out on its own. So we have not tried to pull it out, but it gave away itself. Tissue holding forceps or a mosquito. Something is dazzling. Okay, the retraction is dazzling the field. Very good, very good, very good. Suction inside, beta. using curd mosquito, open kar, हाँ. Catch hold of this thick lining. ये तो retractor का पूरा reflection आ रहा है इधर. हाँ. This is the second increment, large increment of the granulation tissue or cystic lining, whatever you want to call it as. Before it dehydrates, you put it in the solution so that the oral pathologist can give us a clear idea about actually histopathology, because we are considering an apical cyst depending on the radiographic findings, and we are assuming it to be because of, again, precipitating factor for the current issue was foreign body. Now the foreign body is completely out. The lining remains a little bit. I'll go on a higher magnification and focus on the root. Yeah, this is the root apex. We are looking at the root apex here. Bigger size of glove. Bigger size of glove. Give me those gloves. Like, hand is going into spasm. क्या नंबर है वो देना अपने वाले वो अपने वाले दे.
So another question that has come is how will the buccal cortical plate be replaced? So we are not intending to do any replacement for buccal cortical plate because that is not the intention. Nature will take its own course, healing will happen, bone will reform in this lesion, but the complete buccal cortical plate to form will take quite a long time. It may take up to 3 to 4 years for the complete buccal cortical plate to get developed again, but nature will do its magic and it will happen.
The important thing is to take care of the clot that we leave inside the lesion of osteotomy. It will slowly organize to form trabecular pattern and then calcification. So if nature will take, as sir said, nature will take its own course, but aggressively grafting every single site may not be of really of great help. One has to read the literature to understand the need of grafting materials. Okay, we should not do it as a ritual. We need to have a very scientific and balanced approach about usage of any materials for that matter. Because all of us are compelled to do something good, whatever the best possible, but whatever is available as an armamentarium or available in the market as a material or a product may not be good in all cases. So most of the cases do heal very well without grafting. Coming back to the lining that we have left inside, see, this is the remaining portion. We want to curate it out. Yes. This border, we have not exposed the canine. The lesion has extended up to the canine region. So we are dissecting the inferior wall. See, it is coming out with the remaining material, foreign body material here. I will use a mosquito. Grab it. Achha, you suctioned it out.
Gone in the suction, yes.
It's gone into suction.
Yes,
Anyways,
yes.
good. I will continue with the curettage. There is some amount of lesion still presenting here. Rajay sir, I think I should go and curate the apex of the 3 also. छोटा retractor लो बेटा. Take the smaller retractor.
So Minnesota dena, other one, that one, yeah, that will be better. Yeah.
Minnesota.
Will go better in the rib, correct. Full rib, correct, yeah.
Yes. Duck suction इकडे बेटा हा, इथे टाक. हा, I will extend the osteotomy, yes, sir. Now comes the remaining lining and the remaining material here. One more. Wanted to be more conservative in bone drilling. That is why I first completed the curettage here. Okay, everything written in the book need not be followed every time. You see case to case basis. Now, as Sir PD Sir has told me to do so, I will first dissect the soft tissues around the canine so that I don't drill them out with a burr. So this is mostly the caninus muscle, sir, if I'm not wrong. Give an attachment here, so separating it. And now curating out the apical portion of the canine. Okay, this is again the granulation tissue, whatever you call, or the lining. Coming in piecemeal because it's an infected cyst. Don't take it out in suction. We'll send it to pathology for diagnosis.
आले अजून क्वेश्चन आले तेवढे
Now is the time to go after the tip of the canine, and this is the bone. Yes, this is the bone. So now I will do apical root resection of the canine. Put on the, wait a moment, please. You angulate your retractor more horizontally so that I am axially perpendicular to the axis. Yes, better go with the coolant. Yeah, good, better, good, nice. Go on the tip. Retain the needle. Next increment, retain the needle lead. Okay. If you see I'm perpendicular, no, it's dry cutting. Direct well. Yes, good, better. Thank you. I am 90 degree to the axial direction of the root. Yes, complete. You can see apical root fragment dislodged, but attached to soft tissue. I'll remove. Wait a moment, please. Do not move. माची आप हिले नहीं. हाँ, ये देखो, ये जो soft tissue में lodge हुआ है, ये periodontal. Oh my, you may miss it inside. I have to take it out. Spoon excavator, please. It has got lost into the soft tissue. I need to remove it out. Yes, this is the apex. You can see the obturation. I will focus. I can see it very well in the microscope. I can feel the vibration of the air. This is the piece. You see that obturation? Yes, beyond the apex. So the foreign body which was seen beyond the canine, this is the root piece. Apical fragment which I have cut. This is the apical fragment of the canine, okay? See, this is the apical foramen, and this is the extrusion of the canine. You see that? That yellow thing which is hanging out, that was the apex. Okay, and the extrusion of the foreign body which we were seeing in the canine. Actually, I have some problem with the parafocling of the microscope here. Somebody please see that screen if I'm focused properly there and the higher magnification. Okay, because when I'm focusing well, it's not focusing in here on your screens. Retract more. Yes, that grayish lining still exists. Need to be removed. Sir, you nerve to nahi na? Nah, ये कसली है. Quite dark in color the other area. See, sir. Sanjay sir, PD sir, this is to be curated, right? See. Spoon excavator. A surgical scoop or a spoon excavator, they work wonders in these areas. Okay, because these areas are very intricate. The anatomy is very complex, very, very small areas. So they don't welcome other instruments. So you have to use smaller instruments. You see this? The spoon excavator is most efficient here. Can I get a micro mirror now? Micro mirror. Retraction. Last part where our lining remains is this. You can see that lining. I will dissect it now and remove it. So how we have gone? We have gone as per the axis. Okay, not as per the description of the surgery in the book. That is for learners. But once you are on a patient, you are your own judge. You get to decide what you want to do first. Don't go erratic, have a surgical plan. That is why all the plan was discussed with best possible experts here. See that lining coming out? Suction there, suction there. Dissected and removed. Suction, please. Remove it out. This is a blood clot there. Curating the lesion out. Luckily, I don't have to worry much about the mental foramen because it appears to be at distance. Lucky have to not have encountered a major bleeder here, obscuring the surgical field or halting my procedure. If you encounter a bleeder, how do you recognize a bleeder in such a microscopic field? Is that there will be a pulsating bleeding. The moment you look at it, it will fill in. The moment you pack it, it will stop. The moment you remove it, there will be a pulsatile flow. That is an arterial blood coming in. Okay. So that is bad because it obscures the entire vision. Give me another gauze. So we have cut the canine, we have cut the premolar. Beta under, yes. So that we have maintained it inside. So that we have clear vision. Gauze. Suction. छोड़ बेटा. निकालो बेटा, निकालो. रिट्रैक्ट करो बेटा अच्छे से. हाँ अभी फ्लश करेंगे. मुझे इरिगेंट दो. Now is the time when I am doing finer curettage in the areas of intricate anatomy where my bigger curates could not reach. If you can see, I don't know how much you are seeing in the video, but I'm seeing the microscope that I am getting a lot of diffuse distribution of small particles of that calcium hydroxide. I need more suction. Yeah. Using
So one more question that has come in is, can this procedure be done if the patient is on blood thinners? Of course, you can do this procedure even if the patient is on blood thinner. You will need to consult his physician for what purpose these blood thinners have been advised, understand the medical condition behind it. Then based on the risk, the patient will also need to agree to added risk because this is a medically compromised patient. but it can be done. So depending on what type of blood thinners the patient is on, whether he is on long-acting anticoagulants or he is on antiplatelet agents, which are much more shorter acting, decision will have to be taken to discontinue some of the drugs for a few days prior to the surgery. Of course, as I said, physician's consent is primarily required for stopping the drugs.
Material आया है.
And if the patient is on
Calcium hydroxide.
long-acting anticoagulants
Sure,
like
better.
warfarin or the newer drugs that are there, it may need to be done in a hospital-based setup because the patient will have to be transferred from warfarin to heparin for the time the surgery is going to be done, and then again shifted back to his regular medication of warfarin or long-acting anticoagulant drugs. But just because the patient is on blood thinner, there is no contraindication to doing this procedure. Of course, you will need to be more careful. You will need to be more equipped to handle these patients who are on blood thinners.
We have removed the calcium hydroxide, which was encapsulated and embedded inside. Now doing some osteectomy. Any sharp part of the bone need to be removed. Retraction goes apically so that I get access to drill. First of all, I'm refining the preparation of the root end. Then we are now
Copious irrigation with saline is extremely important while doing any of these procedures where you are using a rotary instrument.
about the blood thinners. We find many of our patients nowadays kept on the blood thinners after the age of 40, and everybody is very scared to work on them. But we need to follow the standard guidelines given by various scientific fraternities or various bodies. Auntie, ठीक है ना आपको? So the current guidelines of American Heart Association indicate that dental procedures can successfully be done if the patient is on aspirin. However, if you get a BTCT and PTINR done, it gives you a lot of confidence to work on. Secondly, do not randomly advise the patient to stop the blood thinners on your own, because the physicians will assess the risk of cerebrovascular accident. We need to understand why in the first place the blood thinners are normally advised to a patient. Blood thinners are normally advised to a patient where they fear that there will be a clot which can form in any of the arteries or the veins, and secondly, it can be thrown into a vital organ. So the physicians will assess the risk of cerebrovascular accidents and accordingly recommend the use or discontinuation depending on how important is the dental treatment and how life-saving blood thinning will be. So they are the best judge of making a decision about whether we should continue or avoid. So abruptly stopping at our own end may not be an appropriate choice. Leave it, beta. Mirror, micro mirror. Sir wala, हाँ. So this is a micro mirror to look at the apex. See, I'm focusing on the apex now in the mirror. It seems good. You can see the obturation, and in the canine it's oozing, so control the bleeding. इसके apex पे. Beta, your attention should only be on the lesion. Okay, there should be no oozing in the lesion. You are responsible only for the suction. Okay, keep on suctioning. Retraction also I will only do. Okay, please do suctioning continuously. It is bound together, the oozing. Seems to be good. Over to PD Joshi sir for further management. Mike सरांना द्यायला लागेल तुम्हाला.
अंदर डाल मास्क के अंदर. Okay, so the osteotomy is done, the tissue removal is done, and curettage is done. Also resection, root resection is done. So now what is left is the retro preparation and the retrograde obturation or seal. Can I have a micro mirror? Micro mirror. Okay. In my bag over there are micro mirrors. You bring them. Hmm. There was this. See there, you can open that. Open it and get them. Hmm. There'll be more in that. Right. So I'm going to use a smaller mirror for me to view the apical part. And let me focus as per my requirement. Yeah. And pull it out. Little more. हाँ. आप आराम से बैठो, कुछ नहीं होगा आपको. दुखता होगा तो बोलना. So I'm going to touch the apical part over here. As you can see on this surface. Or at least the premolar is very easy for me to access. बोलता है here ना.
What is being done now is use of an ultrasonic scaler with a special tip for removing the GP point from the apex to create space for the retrograde filling material, which will be MTA. So under the microscope and with the use of special mirrors that you can see, this is a very pinpoint. We are not taking away any dentine or cementum from the root, just removing the GP point at the apex. Dr. Joshi will tell us as to how much of GP or how much depth are we going in.
Usually, it's recommended to go by 3 millimeters.
3 millimeters.
Yes. But a little more, yeah.
Also, the ultrasonics are being used in a probably in a perio mode or no, in a endo mode. Endo mode, and the frequency is kept as low as possible. You can see in the mirror, you can see the GP parts, pieces of GP point getting coming out.
It's the water.
It's just the flow, no?
कमी करायचं. It's washing. The tip is not working. Speed वाढवा, speed. पाणी नाही, speed. कितीवर आहे हे? Speed कशी वाढते याची? बघा टिप किती आहे? डायमंड है इसमें, डायमंड के लिए प्लेन है. Reflect this. ये बस देखिए थोड़ा टर्न कीजिए
This corner of
left take it like this.
take this one if you want.
So you can see over here, there is some amount of preparation done into the canal. And you can even see the GP condensed underneath it. We need to go a little bit more.
Take the other end. Go into the depth of the flap. Very good.
थोड़ा ऊपर So here you can see the preparation, retro preparation in the canal. Are we doing the next tooth now? स्केलर थोड़ा स्लो है. आता ते पटकन होतं ऍक्च्युली.
हो. यात गेलं पण तेवढं नाही.
ट्रॅक करो. It should bring the beat a little bit. Yes. Nine. Hold it properly down. Align. Just very best. Yes, sir, बरोबर. So you can see, even in the mirror view, I can operate to go into the canal. I need to change the tip. It's not working. None of them is working. Okay, so we are almost on the verge of finishing the retrograde. You can see over here on the canine and the premolar. Canine, I'll go a little bit more if possible. Now I'll inspect the canine also so that I know whether I prepared. As you can see, the canine is also prepared. A little bit of GP that has come out is lying over here. You can aspirate it in the suction. If not, we can take it out with the help of the excavator. So now we'll be doing the retrograde preparation, restoration, that is with MTA. So we'll be using MTA putty and inject it into the apical part of the canal. Then we'll be closing. So just check a needle. आ रहा है bro? It comes out of the needle, then we can directly inject. You have a thick needle. You have a bigger needle, those composite compule का needle होता है ना? Flowable composite का needle. वो. इसमें उसमें से बाहर आ रहा है क्या? बेटर. थोड़ा बंद कीजिए. थोड़ा बंद कीजिए. आ रहा है ना? हाँ, so we can inject directly. As you can see, I'm inserting my tip by about 3 millimeters, and that is my preparation. Same with the other tooth. I make sure that my tip goes by about 3 millimeters. You can see GP being pulled out. And once that is cleared off, you can now visualize the apex. Hold the suction close so that mirror doesn't fog. Yeah. And now you can see the apex. Over here. I hope all of you can visualize this part. And I can even use the same instrument to clean off. So it is all ready now, so we can do the MTA placement at the apex. I'll be first washing off a little. Then we'll be placing the MTA. You don't have to really worry about drying, over drying, because MTA sets in presence of moisture. So just suctioning should be enough at the tip. And now I'll be placing MTA. As you can see, it's injected directly into the apex. The another one. Again, I'll be injecting directly into the apex and excess will be carved out. So use the reverse end of the. There are carvers available if you want to have them. There are ways and means of smoothing this surface. Normally, I prefer to use an applicator tip, but you can even use a small cotton pellet or a gauze surface. Now this will dry out by itself and set by itself. You don't need to do anything. Let's inspect how it looks. And you can see it's filled up the apex. You can replenish it if you feel, that it's not sealed well. I'll just do it one more time so that I'm sure that I've put MTA all the way to the end of the canal. You can even use some instrument to condense. And make sure that it has entered deeper. MTA plugger रहेगा. We also make sure that we don't leave behind any MTA extruded because we need to wipe out all. And as you can see, I have removed the excess MTA from the surface of the root as well as surrounding area where it might have gone. Can you retract a little more? So now I have a clear view of the apex with the MTA right at the apex. You can see it's completely sealed. And same thing with canine. And I need to just clean the canine apical part a little and then we can start suturing. Okay, so it's all ready. We can close the flap and suture. First of all, adapt it well on the surface so that it can be sutured easily. You need a tissue forceps for retrograde is done. And we need to just close. Mm. This is the material we used. I need to reduce the modification, which is a direct putty. So you can actually inject directly like this into the apex. So everything is matching the needle size, the apical size, and your preparation size so that it just fills in. And then you wipe it off the excess. All right, so this is where we will start suturing. I have the suture with me. First, I'll suture the mesial part so that the flap remains stable. What the size? 440. 30 is too big.
So we saw how wonderfully the microscopic retrograde sealing of the apex was done by Dr. P.D. Joshi under microscope and with the use of ultrasonics, special tips on the ultrasonic.
Tip we used.
This is the same scaler that we use every day for general perio work, but the tips are very special and we use a endo mode in a low frequency for using this. So there is one tip which takes out the GP point from the apex. So and a depth of about 3 millimeters is what Dr. P.D. Joshi said that you are supposed to reach and remove. So 3 millimeter of GP point from the apex, followed by prepping the apex with a diamond impregnated tip on the ultrasonic scaler. Once that is done and you have flushed the area well and dry it up to the extent possible, and then you use, now we have MTA putty which is available in a syringe. So there is no, the handling of the material becomes much easier. You can directly inject this putty into the prepped retrograde cavity that you have prepared. Remove any excess, if at all, that is there around the root. Once that is done and you have achieved hemostasis, you reposition the flap and suture. So now, Dr. P.D. Joshi is using, I think, Vicryl,
My career,
maybe 40 Vicryl being used.
50.
50 Vicryl is being used
Open
for suturing of the flap.
Will you move? So you,
So initially, all the papilla to papilla is what will be sutured first.
then you go interdentally towards the lingual.
So the suturing is also very important. You must get good closure and a watertight closure, which is extremely important.
I'll be going towards the, through the contact point into the lingual over here. And then take a bite on the lingual surface. Once I've gone through, I'll pull the needle out,
So
but
the papilla on the buccal side between the second, between the lateral incisor
canine
and the canine. Then we go through the lateral incisor and the canine on the lingual side, take a bite, the lingual papilla between these two teeth. Sir.
so lingual bite is taken. Now I'll be bringing the needle back again to the labial surface. So you can see I can go through the contact point like this or like this. And then I can suture it. So the flap is positioned and the suture is given so that, it doesn't move. And the edges are aligned properly. Now can we have the scissor please? Cut. थोड़ा 3-4 मिलीमीटर, इतना बड़ा नहीं. कम कर दो इसको. Now you can align the flap towards the mesial so that you take a bite from the flap to the towards the buccal. Hold it like this. And then you close the flap. Make sure that the edges are aligned. And then you pull it. And you can see it's closing off well. And we can cut. Just cut 3-4 millimeters. Don't cut. So just one suture and the flap is almost closed, but you have to give more. So vertical incision is now getting closed first. Because the choice is yours. You can even close the papilla to papilla first and then close the cut kar. I'll give one more so that it becomes completely closed vertical incision. So as you can see now, the vertical incision is completely closed, and we can still, the relieving incision which Dr. Abrar had given, we can close that as well, so that it will stop bleeding from there.
So now the suturing is almost through. As I said, we did papilla to papilla suturing first, followed by the vertical incisions, the distal and the mesial one. What has been used is a 50 Vicryl, which is a resorbable suture.
थोड़ा खोलिए मुंह, मुंह खोलिए.
So another question that has come is, how can we decide that granulation tissue is being removed completely? So this is completely based on the operator's skill and the magnification that he is using. So that is why the need to use more and more to use magnification, whether you are using loops or if you have access to microscope, you must use a microscope. And that is what will ensure that proper removal of granulation tissue or cystic lining has happened. And you should be able to see nice yellowish bare bone. That is why it is important that we use more and more use magnification in our practices. The tip, as I mentioned, these are special tips available for ultrasonic scalers or ultrasonic equipment for retrograde cavity preparation. You can ask your suppliers of dental equipment and they will give it to you.
I'm giving a circumferential incision suture.
So in addition to using interrupted sutures, we can also employ circumferential sutures for larger flaps, which goes around the tooth completely. So it's like a horizontal mattress. Circumferential suture will be almost like a horizontal mattress.
So this will give us, close adaptation of the cervical area of the gingival tissue to the tooth.
Always.
Last suture.
Okay, wipe the tissues clean.
आरवी होणार का इकडे करून नंतर So we are now in the final stages of completing this case, which we started maybe almost an hour ago. For the first premolar, which had developed a periapical pathology, a significant amount of osteolysis was there. It was decided post obturation, it was decided that it would need a root end surgery, and the root end surgery was planned for today, and it was beamed live to all of you. After giving local anesthesia, inferior alveolar nerve block, infiltration, trapezoidal flap was raised from the canine to the first molar. After raising the flap, since there was no buccal cortical plate, the lesion was completely exposed. It was there for us to see. The foreign material in terms of metapex or the calcium hydroxide that was introduced earlier was curated and removed. The root resection of the first premolar was done. Along with that, the foreign material that had extruded into the osteolytic cavity was also removed. Curettage of the osteolytic lesion was very important, and that took some time because these are very tenacious tissue within the area, and you need to have good sharp curettes to remove it. And you saw how magnification helped in removing every tiny bit of this granulation tissue or cystic lining, depending on what the histopathology will tell you now. And hence magnification was very important to do a more satisfactory job of these lesions. Post enucleation of all that tissue and removal of all that tissue and curettage with constant flushing with betadine and saline, root resection of the adjoining canine, which was also involved in the lesion, was done. Further tissue that was attached lingual to the root of the canine, all curettage from there was done. This procedure was done by Dr. Abrar. Following that, Dr. P.D. Joshi has taken over and he did the retrograde prep and the retrograde filling with MTA putty. After that was done, the hemostasis has been achieved and suturing has been done with Vicryl 50. We don't expect any complications as such because the surgery has been clean. There is no tissue trauma. Patient has been comfortable all through the surgery. What is important here, as I mentioned earlier, was the magnification. It is only the magnification which has helped to do a successful surgery, and I'm sure the outcome of this procedure will be very good. The healing of this lesion will take a long time. It doesn't take just 3 months or 4 months. This kind of a lesion to heal, good results will be seen radiographically only after 2 years. And it is important that these patients follow up with us regularly every 6 months just to take a radiograph and see how the healing is progressing. So with these few words, I hand over to Dr. Abrar for his closing remarks.
Hello, everyone. Thank you for watching us. Thank you for registering and encouraging us by participation. And thank you for the wonderful comments that people have posted on the groups and on the YouTube. And thank you for those questions, which we found A few of them were basics, a few were very elaborate and subjective questions which we could not answer, and few were really intriguing and will definitely guide us to do better work in future. And somebody has posted about retrograde restorations. We approach the canal with retrograde approach to solve a problem. Surgery earlier was supposed to be for removal of the pathology from the apex. However, high incidence of failure was recorded with these surgeries because the effect, that's the pathology, was removed and not the cause. The cause lies inside the canal. So these are the lesion of endodontic origin. So if you want to control them, cure those areas, we not only have to curate the pathology, but also need to take care of the root canal. Now, why in the first place these lesions develop? These lesions develop because orthograde approach of the root canal has failed to obtain good debridement and subsequent three-dimensional obliteration and infection control. So an appropriately done root canal also does not solve the problem, and there is an apical ingress. The infection thrives and grows in the apex, and granulation tissue forms. Their cystic lesion form, they become expansile, and they cause a lot of damage. So what do? We first of all do not go behind the pathology surgically. We intervene non-surgically. We open up, disassemble the coronal restorations. We go behind the root canals. We remove the obturation. We explore all the canals, all the surfaces of the root canals, do a good obturation, and wait for ample time for a natural non-surgical healing to occur. Once the non-surgical healing is complete, we don't touch it. If we fail to achieve non-surgical healing, then only we plan to surgically intervene. Now, how do we intervene? We've been showing a lot of surgeries on this channel. Come back again and watch these surgeries. Now, talking about the root apex, we cut apical 3 millimeter of the root because it contains maximum anatomical complexities, lateral canals, ramifications, or accessory canals, accessory foramens, irregularities, resorptive defects, fractures. So we resect the apical 3 millimeter of the root so that the microscopic small fragment of infection and the remaining pulp are removed along with the resective area. Secondly, we send a mirror down there inside the lesion to visualize the obturation from the apical end. We go 3 millimeter coronally from the apex into the root and remove the obturating material, and we prepare a cavity with parallel walls. 3 millimeter from a retrograde approach, that's the norm. We use zirconium nitrile coated ultrasonic tips to do so. Each and every single tooth and every root has got a different angulation to itself. So there are tips designed for each root differently. We select an appropriate root tip. I strongly recommend you to study the root tip to be selected. If you select a wrong root tip, you botch up the entire case and hard work that we have done. So now finally what we do, once we prepare the apical cavity, 3 millimeters, we mix a bioceramic material and we compact that material well in the entire cavity so that a biocompatible material remains inside the tissue contact and there is a conducive atmosphere for healing. And then inside the canal, as these materials are known to have good apical seal, good contact with the tooth surface, it will not allow micro leakage, percolation, and will break the contact between the dormant flora of the canal, which has been entombed or sandwiched between the obturation and the root surface, does not receive any nutrition from the apical exudate to thrive again to cause repeated endodontic failure, which we currently call as post-endodontic disease. I hope I explained the whole matter correctly. Thank you so much for being with us. Thanks once again. We are now signing off and we will be back after 5 minutes with the next case. Thank you so much. Bye-bye. A very good afternoon to one and all. Thank you very much for joining back again with us. We have completed the first case and we are back with the second case. As discussed and declared, we were to operate apical cementoblastoma of mandibular left first molar. I will present the case in brief. The 52 years old female patient is reported to the department with the chief complaint of pain and swelling in the lower left side of the mandible, this area. The tooth was decayed. This is 3-6, mesial caries and tender to percussion, severe pain. So the tooth was treated by access opening, extirpation of the coronal pulp, emergency management, and patient was referred for radiography. The lesion indicated that the mesial lesion was approaching the pulp, good amount of obliteration of the pulp due to calcific spicules was found, and we saw an apical radio opacity. In the various projections, intraoral periapical radiograph shows that there is a dense area of radio opacity in relation to the mesial root, almost touching the distal root. Now, if you see this lesion has caused a discontinuation of outline of the root. Usually in such cases, we have to discriminate between fibrous lesion and lesions of inflammatory origin. If this would have been a lesion of inflammatory origin, meaning if there is a dense area of bone forming, condensing osteitis, or a dense island of the bone inside the bone, the outline of the root will not be disturbed. Anyhow, the PDL will cast a very small shadow, discriminating it from a fibrous lesion. However, here if you see, no trace, no sign of an PDL or outline of the root can be seen. So clinically, it can be considered to be a cementoblastoma, which is fibro-osseous in origin. And if you see this here, the 7 also has similar lesion, but you see a clearly outlined border between the opacity and the root apex. So that discriminates this lesion from this lesion as of now radiographically. However, the symptoms are present today with the 6. We need to take the endodontic approach. At the same time, this lesion should not eat away the entire bone, so we need to resect it and control it. Traditionally, these lesions have been treated by en-bloc resection of that part of the mandible along with the extraction of the tooth. However, all the modern gadgets and tools that you have been demonstrated since morning to our disposal, we are thinking of resecting the apical 1/3 of the root and the resection of the pathology here. Once the pathology is resected, we will do a retrograde approach here. That was the original plan of action. Working length was determined, master cone was taken, tooth was obturated. You see obturation. Further investigation with the CBCT. Some places the lesion appeared to be overlapping the distal root. However, all projections, axial, sagittal, coronal, all that we have taken, one thing is common, it is surrounded by a radiolucency, clearly outlined borders, which is never a feature of condensing osteitis, usually. So what is happening here is this area is hypodense and need to be removed. Patient is a known diabetic, and this is to declare, unfortunately, we have been tracking the patient for last 1 month. However, but today when random blood sugar was taken, her blood sugars have come out very, very high, and the physician has declined us permission to operate today. So I apologize, but these are circumstances which can't help. So we decline to work on this patient today, and she will be posted back again after we control the blood sugars. So to avoid disappointment, what we will do is we will record the surgery as and when the patient is fit to undergo a surgical intervention. We will record that surgery and put it up on the same YouTube channel. Okay. So you can go to our channel once it comes our channel, and then you can watch that surgery. In place of this, what we are doing today is another case which our second unit had already started while we were operating on the first case. He is a 50 years old male patient, complains of swelling in the anterior region and pus discharge in the anterior mandible. Patient give a history of trauma 35 years back, and on examination, obliteration of the labial vestibule was seen. Is the patient? No obvious extraoral asymmetry was observed. However, if you can see, the lower anterior area appears to be swollen. OPG indicates the lesion extending from the midline up to the mesial of the root tip of the fore. In the third quadrant again, interoral periapical radiograph shows extensive lesion. Working length was determined, access was opened, master cone taken and obturation completed of the teeth involved. These are a few CBCT images. You can see there has been total loss of the buccal cortical plate. However, in most of the places, lingual cortex appear to be intact. Here also, it is confirmed that angulation from paraxial views. All the paraxial views also indicate that we may not expect a perforation there. So in a last few surgeries that we have demonstrated online through this platform were all maxillary surgeries. So this one is a mandibular cystic lesion that is being operated upon. Dr. Divya has already raised a flap. She has exposed the pathology. We have completed the curettage also. Now we are at the stage of root resection and retrograde restoration. So over to you, Dr. P.D. Joshi, sir. He has already started opening up the tissue. After curettage, we control the hemorrhage and perform further procedures. So the patient was given a pack for 5 minutes to control the bleeding. And now the bleeding is controlled. We'll proceed toward root resection, retrograde cavity preparation, retrograde restoration, and closure. Over to PD, sir, for clinical procedure. Thank you.
Okay, so you can see over here this is the root, and you can see I can approach the apex and reduce it. You can either cut by 3 millimeter or you can reduce it by 3 millimeter. It's your choice. And we can examine this with the mirror to see how much we have reduced. Okay. लाइन लेना, मिरर अच्छा देना जरा। So you can see the apex of both the teeth very clearly, and there is a little bit of granulation tissue around the apex of the lateral incisor. So we need to curate that. Do you have a small curate? Give me. We have a better mirror. Can I get my mirror? Can you get that mirror from there? Just open this. Do this. Keep it in this. Take this mirror out. Take this mirror also out. Okay. Take this off. उसमें दिख नहीं रहा है लेकिन. Just open this. Check this. और होगा अंदर. हाँ. हाँ, दोनों ओपन करो. थोड़ा गॉस पीस रखो यार. Shall we go ahead and do this? Set a crack. टूट गया मेरा. दूसरा टिप देना तुम्हारा वाला. डायमंड वाला देना. हाँ. Now keep the area clean and dry so that I can show it. Retract. So as you can see over here, there is a kind of a isthmus on the canine, so we need to clear that as well, and then seal the entire thing. Okay. Yeah. So this isthmus has to be opened and cleaned so that you can seal it well. I'll use a smaller mirror so that you can see it much clearer. Hmm.
So you all can see here, sir is operating for retrograde preparation. You'll see the tip has been angulated in such a manner that it prepares the canal parallel to the long axis at which the canal is running inside the root. One has to ensure that the root tip selected is appropriate and works in the same direction. And osteotomy has to be done in such a manner that your root tip can be placed inside the canal well. So when we cut, mostly we cut with the direction and angulation of the obturating material. Once your instruments keep vibrating, there are two types of tips available. One are self-irrigating. That means there is a small opening in the shaft of the tip from where the irrigant solution comes. Okay. And that provides coolant where the cutting is happening. But however, once you are working inside the root canal, you don't get the action of the coolant. So the ultrasonic vibration of the tip generate heat, and heat plasticizes gutta percha in the apex. So your tip directly glides inside the canal, plasticizing the gutta percha and taking the gutta percha out. So we try not cutting the dentine, but we mostly glide on the surface of the GP down coronally and ultimately making the tip. And in these cases, usually, as we know that more than 40% of the center incisors and lateral incisors have bifurcations. So we may anticipate an hourglass shape or dumbbell shape to the microanatomy of the apex. Hence, as sir described, isthmus need to be explored and negotiated and prepared if need be. Sir, is there an isthmus for the canine also, sir? Because lower canine also has.
Canine.
It is there on the canine? Okay.
You can see it, I can show you. Yeah.
Okay. Yes, 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 yes. You can see the isthmus. Indirect vision. If you control the oozing a little bit there, it will be more obvious in the mirror. We will be showing it to you in a micro mirror again.
Now you can see it. Dr. Abrar, can you see it now?
You all can see it now. Yes. See, it has been focused. The apex has been focused there. Yes, you can see a beautifully prepared access retrograde cavity with uniform thickness of dent throughout peripherally. The cut of root resection also has gone beautifully, absolutely horizontal, which is perpendicular to the long axis of the root. Sir has taken up the second tooth now. So let's complete the second root apex.
Irrigate करो साथ में suction पकड़ो.
Because of the prolonged use, our camera which is relaying and recording the procedure has lost its battery. The battery is almost dead. So we go offline for a while. For a minute's time, this time we change the battery. Please change the battery. Mask लगा के जाओ. Offline. Okay. Do it. Do it. मेरी तरफ से. मेरी तरफ से. Change हो रहा है. So as I was describing, this is a very important step. that we use proper size of the osteotomy to visualize the apex. We resect the root apex. We prepare a retrograde cavity and fill it. If
Hold it.
you do not have provision, if you do not have access, if you do not have correct instrument to take the cut, and if you don't have instruments and tips to prepare the apex, might as well not do it. Because I have treated a lots of complications where people have filled massive amount of restorative materials inside the bony cavities without realizing the root apex, where it is. Because once you open the tissues and cut the bone, dentine color and a healthy bone color is almost similar. In previous cases that we have done, in a massive trauma case that we relayed live, we also were unable to locate the root piece. If you remember, India ink is used. We take an applicator tip, dip it in India ink, and move it around inside the osteotomy lesion, and then rinse it off. The moment you rinse it off, the entire dark solution comes out, and the periodontal ligament will take up the color. Clearly delineate itself as the periodontal ligament, then you know where the root fragments are. This is very helpful in cases where there is no osteolysis, especially cases with broken instruments, vertical fracture, you want to remove horizontal root fracture. Such cases, it is of high value. It is very, very important that we know where the root dentine is starting and where cementum starting and where the bone is. At times, people do the whole work in the bone, not realizing where the root was. And later on, we find, especially in the upper anterior region, the root was distally and palatally curved. So I strongly recommend that you find the root apex first. So what we prefer if the root is open, if the apex is open, we usually tend to overfill the root canal, overextend the fillings, so that the moment flap is raised, what you see is only the blood, so you don't see where the root is. So that overextend obturation flag us about location of the root. Going back to the camera again, in the surgical field, can you focus it back to the surgical field, please?
So here you can see the palate preparation of the lateral incisor now. Now, can you see the lateral incisor? I will just magnify it. So you can see it over here, the apex of the lateral incisor. So I'll be just preparing a little bit and then we are done. You can also use the same tip to remove the granulation tissue and make sure that everything is clean around it. As Dr. Abrar mentioned just now, the visualization is there. One person can irrigate while we are working. Now clearly visible the apex of the other one. So both the apices are visible to us, and now we can place MTA. But before that, we'll isolate the tooth so that it's easier for us to pack MTA. So we'll be placing some gauze in the apical area. And also some small pieces of cotton or gauze surrounding the root apex so that the blood doesn't ooze onto the tooth. Keep it dry, the gauze, don't keep it wet. Keep the dry gauze. So this gives us access to the apex without the blood oozing onto the apex. And we just simply inject. Retract करा थोड़ा. No, I'm about to place. About to place. Give me a tweezer. Retract. Retract and hold suction. थोड़ा सा गॉज लगेगा अंदर अंदर रखने को. The bottom. छोटा रखो, एकदम छोटा रखो, क्योंकि वो ऊपर आ रहा है ना, कैनाइन एकदम डीप है. Keep it here. And now hold your retractor. No, I have a mirror. Hmm. दिख रहा है? There's a lot of blood oozing. एक रेट्रोग्रेड डाल दो, कैनाइन का डाल देता हूँ. Quickly डाल देता हूँ before the blood oozes. Let's see. Wipe it off. कुठे?
थोडं ग्रॅन्युलेशन येतं.
असेल.
ओके बट गया ना. रेट्रोग्रेड कंडेन्सर. रेट्रोग्रेड कंडेन्सर. ठीक है.
और क्या?
मटेरियल ध्यान में दिख रहा है. कॉम्पैक्ट है. देयर इज मटेरियल. या. Yes. Good enough. Good. Good. Excellent. Yes. Is right?
I can also see.
Yeah, material is good. Right? Right. सबको लाइव आने. आ रहा है. इधर बैठते लाइव आने. आप इधर से लेट हो गए.
Okay. Is it okay? डाल. Okay, so Abrar will take over.
Thank you so much, Joshi sir. It's always been a guiding force for us. Control the hemorrhage. Oozing is because of the small fragment of this granulation tissue here, which, see, this is the granulation tissue that was causing so much of oozing. So we need to be removing it. Now pack that area. Wait. Is a hemostatic solution? You may not need it, beta. Let's see. Instrument. Give me another. बेटा उसको डिसइंफेक्ट करके दो. Tweezer here. Leave it. Yeah. This is the wrist. Now I will show you tweezer, please. Don't keep anything on the surface here. Open. I'm showing you the root apex of the canine. If you all can see it through a micro mirror, I'm showing. See, it is well condensed. The retrograde cavity is well condensed with the, and this is the apex of the lateral incisor. It's a saturated hemostasis solution, no? Source. I will increase the magnification to show you where this is the apex. What I have placed a small mirror in the apex. Retract. Curating the lesion around it to stop the bleeding. The lateral incisor, no, still oozing. I'm getting that bleeding needs to control. Do we have Surgisil here? Give me Surgisil if you have. Give me betadine, please. The lips are drying. The tissue need to be hydrated. Always ensure that during the surgery, the lip and the hard tissues of the teeth are always moistened continuously. Avoid dehydration. That's the preparation sir has done. It's a nice preparation. I'm focusing it in the microscope now. The center. The area around it is having a granulation tissue. That is why it is oozing. I will cure it out. Suction hold kidan. Don't drop the suction. Yes, see, this is the granulation tissue around the root, which has been oozing. I am working on almost magnification of 30 here, very high magnification in the apex. And I'm doing the curettage of the root tip from retrograde approach. Suction it out. This has to be out for us to control that bleeding. And there is a small sac of this granulation tissue which is hiding parallel to the root surface. So I am curating it out. चलो सेक्शन इधर रख. तो छोड़ बेटा, छोड़. हाँ, still losing out. Suction. No, sir, oozing is the problem. There's no hemostasis. ये solution है अपने पास? Give me the solution. अरे ये पेशेंट के ऊपर कुछ मत रखो. दे दो, इधर दो. बस. सोडा. नमक इस करना का. We need absolute isolation for the MTA to work. So we are spending time here to achieve hemostasis. Open. निकाल बेटा. This is the canine. यहाँ पे एक छोटा आर्टरी है. एक मिनट, कोई इंस्ट्रूमेंट है कि इसको दबा देता हूँ. No, this is the nutrient canal which is bleeding. It is not the tissue. See, this is the nutrient canal where I placed it. Now there will be complete hemostasis. See this. That is a nutrient canal which is bleeding, where I have kept my spoon excavator disc. I will control it by holding it. Let it coagulate. Then I will allow clot. See, if I remove it, yes, it is oozing out. It's a nutrient canal. It's an arterial blood is coming out. So it is not stopping at all. सर्जी सिलाई थोड़ा सा अपने बस ब्लॉक कर देंगे उससे उसको. स्पॉन्ज है सर्जिकल स्पॉन्ज. बोन वैक्स है के दे. बोन वैक्स है तो दे. तर काही ठेवायचं नसतं बेटा. कुठे दे मला. हा करा. हा. Yes. Wall furniture. Good. I can see the effects now. So let's complete the deposition of the material. कर बेटा, एक्शन करत राहा व्यवस्थित. पकड़ा. थोडस बंद करा. हा बस. बस. Don't block my visual access. Action. Using a round condenser. कर. For the retrograde compaction. Action. You can appreciate presence of material in the apex here. See this. See that? Exact localized placement. Test the small bolus, and I'm compacting it there on the root tip. Getting compacted. This is the apex of the canine. You see that? We have compacted. Now we start closing. Chalo beta. Anchor suture goes in the midline. Sorry, in the middle of the flap. What we are trying to do now is a repositioning of the flap. Sometimes the flap can get dehydrated after a long time, so surgery. So we have to sometime do some blunt dissection and do more flap raising so that we can compensate for the loss of moisture in the flap. Retract. बरं आहे ना काका? Suturing. Needle holder. Oh my God. हे दुसरं दे, हे दुसरं दे. सुचर दुसरं दे, गेले खाली दे. सुस्ट्रिंग मटेरियल दुसरं दे. डिस्कार्ड करा दे. Effect of LA is wearing off. So we have to be quick. Fibers, the cotton and gauze, microscope shows us. So we remove because these are going to cause inflammatory response in the tissue if they remain. This is the papilla to be replaced here. So we are going to ensure that the closure remains good. Taking a bite. Hey, do not move. Hey, don't retract. The anchor suture is in place. Thanks, surgeon's knot. Slightly loose so that the flap available can be displaced as per the requirement later. Over tightening at this stage can cause displacement, and too tight a closure on one side and lack of closure on the other. So one has to be careful. If I feel like, I'll remove the suture later on and do it again. You continue suturing. Continue suturing. इधर से जो बाइट लिया था ना लिंगुअली वो फट गया, इधर इधर से लिंगुअली।
मला सांगा चालू झालं सांगा on. Good afternoon, everyone. I am Dr. Manoj Ramagode, Associate Professor of Department of Conservative Dentistry and Endodontics. Now we are at the end of the session. In few minutes, we will complete the surgery. Before that, I want to remind you all that we have to fill the feedback form. It has not been filled by many of the participants. Kindly fill the feedback form so that we will get to know what is wrong, what is right about the surgery, what are your opinions. Please kindly fill the feedback form. As well as I want to remind you that the next session will be coming soon. We will announce soon. And I thanks all the participants who are participating actively by seeing this surgical program. I thank Alchem as a educational partner, and I thanks Dean, Government Dental College and Hospital on behalf of our HOD for giving us this wonderful opportunity to work on patient and for the betterment of the patient services. I am concluding the session within 2 minutes. Once it is done, we will put up the video. And last, once again, the reminder for the feedback form. Kindly fill the feedback form. Thank you.